Welcome everyone. Thank you for joining us today's webinar. My name is Marian. Today we are presenting a paradigm shift in quality improvement and patient safety using live simulation and computer modeling presented by Dr. Sapan Desai. He was formerly the Vice Chair of Research and Director of Quality Alliance and Predictive Analysis for Southern Illinois University. He is currently the Chief Executive Officer of the Surgisphere Corporation, a medical education and consulting in Chicago, and Director of Quality for Northwest Community Hospital in the suburbs of Chicago. Dr. Desai is also a clinically busy, double board certified vascular surgeon with over 200 publications and textbooks. His group was awarded the International First Prize in the poster competition at the 39th World Hospital Congress and was recently awarded the highly coveted McKesson Award for Quality. Just a housekeeping before we start. If you have any questions during the webinar, you can enter your questions in the questions pane and click send. The presenter will be answering questions after the presentation. Today's webinar will be available on demand at the IHF website. So now, without further ado, we will turn the time over to Dr. Desai to start his presentation. Dr.
Hi,
Desai?
Marianne. Hi, Marianne. I thank you very much for that very nice introduction. I'd like to thank the IHF also for making this opportunity available and for all of the attendees we have from all around the world who are setting aside about an hour to listen to this talk. I certainly hope you'll find it interesting. So as Marianne has very nicely introduced, I'll be talking to you about a paradigm shift in quality improvement and patient safety. And basically, I think that the shift is happening using two important tools, basically live simulation and computer modeling. So without further ado, we'll get into it. I don't have any disclosures, there's no conflicts of interest or any financial disclosures. So let's start by defining quality. This is really the focus of the talk, and it helps to have a good definition of it. So quality is the standard of something as measured against other things of a similar kind. Now, put another way, it's the degree of excellence of something. And I think when we start talking about quality improvement and systems-based improvement in the hospital, we really forget what we're doing sometimes. Our focus is on the degree of excellence of what we're trying to achieve. So basically, quality improvement, unfortunately, tends to be a reactive process that seeks to correct defects. In healthcare systems, defects typically involve patient harm or a near miss event. And there's many situations that involve numerous variables and complicated clinical settings, and that complexity can sometimes make the process of quality improvement very frustrating. And so the purpose of this talk is to demonstrate a new pathway that makes quality improvement a prospective process. That gives you a lot more control over this process. The pathway that I'd like to talk to you about prevents errors from ever occurring. No patient harm or near miss event is even necessary and never occurs in this framework. And the great benefit of this approach is that this is a scalable, flexible, and efficient pathway, and it can also be readily implemented by any healthcare system in the world. So when you're talking about the current state of the art and you're thinking about the way we do cause analyses right now, basically you've got a variety of different components: people, methods, materials, environments, and measurements, and they all are responsible for somehow leading to a particular problem. Now, for anyone that's ever done a root cause analysis, you all know that there are many causes that cause this individual problem. And because you can't control all of these different causes, you never really solve the problem. In fact, one of the issues I deal with sometimes is that we'll do a root cause analysis for a particular problem, and we think we've solved it, and a few weeks later, the same problem happens again, and this time it's a slightly different cause. We haven't really fixed the underlying issues. So basically, that leads to failures of our current practice model with this retrospective root cause analysis, quality improvement type pathway. And it's got a very narrow scope. And because of that, it only solves small, focused problems. There's no systems-based quality improvement that happens. And because of that, similar problems continue to occur because of these other causes. And people on the quality team start getting quality fatigue because of this lack of progress. When you start looking at things from a structured framework, many people use something called DMAIC, which is part of the Lean Six Sigma process. Now, DMAIC, many of you are probably familiar with this, but I'll go over it for anyone who might not be. DMAIC stands for Define, Measure, Analyze, Improve, and Control. The D defines a problem. And for our quality improvement projects out there, basically these defects are identified through peer review, risk management. Unfortunately, the problem statement tends to be too narrow when you do it that way. For measure, you map out the current process. Many times the mapping is done by Lean Six specialists, and those folks are not necessarily clinical specialists. If for analyze, you identify the cause of the problem, and the root cause analysis offers a picture of some of the potential sources for the defect, but like I said earlier, very narrow focus and misses other causes. For improve, you want to implement and verify the solution, and if you do a good RCA, you'll usually find one or two specific causes that you can fix. The problem, of course, is that you failed to correct dozens of other common causes of that error and really haven't solved the problem. For control, you certainly want to maintain the gain so that you haven't gone anywhere. Unfortunately, what you've really succeeded in doing with most RCAs is preventing a specific cause of a very narrowly defined defect. And like I said, similar errors continue to happen from all these other causes. Well, there's a better way. And you can look at this article online, but the hospital that I previously worked at, Memorial Medical Center, I had the unique opportunity to work with a very, very nice team of Lean Six Sigma specialists, simulation specialists, in a wonderful building that was actually set up just for live simulation and had dedicated facilities, including like an operating room, emergency room, and even an ambulance on the third floor of the building. Now, you don't need similar facilities to do what I'm about to show you, but I'll show you some very interesting pictures and how we were able to pull this off. What it ended up being was actually the world's largest, most elaborate medical simulation ever conducted. And we actually learned quite a bit from this, and this is where this prospective method of quality improvement kind of comes from. So I'll go through a case study and kind of show you by example how this was done. So the problem at hand, 90% of patients with a ruptured aneurysm die. And unfortunately, that statistic hasn't changed. Despite 20 years of advances in medicine, there's been no impact on that survival. Now, many of these deaths are actually due to delays in clinical care, and I'll show you an article that published that talks about that. And so what I'd like to show you is a team-based solution that actually helps fix that problem. Now, this is that article I'm talking about. We actually did a database study using big data and figured out what the change in mortality is over a period of time for patients that come in with this very, very nasty disease, a ruptured abdominal aortic aneurysm. Basically, what you should know about this disease is that it's a balloon-like dilation of the biggest blood vessel in your body, and when it ruptures, there's a 90% chance that you're going to die from it. You start bleeding internally, your pressure drops. Most people don't survive this. Even if you were in the hospital in the presence of a vascular surgeon and you ruptured, your mortality is still over 50%. And like I was saying earlier, we haven't been able to improve that mortality at all in a very long time. So our project was to fix that. And so we started looking at all the different things that were critical to the quality of care that we were providing. And really our output was to get proper and timely activation of the OR, because when we started looking at our processes, we realized that there were multiple delays in basically being able to get a patient from the emergency room to the operating room. And so in order to get proper timely activation of the OR, you need to have the right diagnosis, you've got to make sure you actually need an operation, you have to have quick and effective OR activation, and you also need direct lines of communication. Now, I'm not going to go through all this in detail, but for those of you who are familiar with the Institute of Medicine and the 6 aims, you can see that many of them are actually represented here for the customer requirements. Now, as part of this project, we also did failure modes and effect analysis. You can think of this as like a risk register, and basically figured out what the most common or the most serious adverse events were, their impact on care, and how likely it was for one or more of those events to actually occur. And if it actually happened, what the severity of that incident would be. Now, we also came up with various mitigation strategies to decrease the impact and the severity of each of these events. And that's what this case study actually goes through. Now, I was telling you earlier that when you're in the process of measuring and analyzing, you have to make sure you have a very good process map. And so we developed this. We basically figured out all the different steps a patient goes through, from the onset of symptoms at the scene to the ambulance, to the emergency room, to the CT scan or the operating room, and finally to the ICU after surgery. And it turns out that there's hundreds of steps, and it involves dozens and dozens of people, and there's a great deal of coordination of care. However, even though that's a very complex scenario, one of the things that we found in process mapping or communication matrix was how complicated it was. It shouldn't be this complicated. The ER, the emergency medicine attending that diagnoses ruptured aneurysms, has to call a variety of different people who then play a game of telephone. He calls the emergency room clerk, who then calls the OR clerk, who then calls the OR charge nurse, who then calls the operating room team, and the ER attending also calls the surgery attending, who then touches base with a variety of different people. Now, this is ridiculous. I mean, you think back to when you've played like a game of telephone, and by the time the message gets around the room and back to you, it's completely different. So, and unfortunately, because of the lapses in communication, we actually saw a major degradation in the quality of care we provided, and not just for ruptured aneurysms, but for a variety of other issues as well. So I won't go into this in detail, but basically, we found a variety of different defects with the current model of care that we were providing, and our baseline performance, this is a control chart, our baseline performance was completely out of control. Really, only 1 out of 41 patients we looked at actually met our specifications for getting the patient from the emergency room to the operating room within 2 hours. Only 1 out of 41. And so we had a 97.6% defect rate, which meant that 40 out of 41 patients were spending a lot more time than they should from getting into the door of the hospital to on the table in the operating room for surgery, emergency surgery. And so we saw these processes and said, this is unacceptable. We can and need to do better than what we're doing right now. And so, you know, when you're dealing with good quality improvement, you also need to have a return on your investment. You need to know what your direct costs are, and we did that. What you're looking at here on this table is actually just the direct costs for false activation of the operating room. This is when you call in a whole team of surgical first assistants, nurses, anesthesiologists, and many other people who don't end up you actually doing an operation because you either had the wrong diagnosis or the surgeon decided that the surgery wasn't even necessary. So this is $250,000 US dollars in 2015 of actual direct cost, total waste that actually occurred at one hospital in Illinois. So we figured out what the source of these delays were and where some of these costs were coming from, and we realized that the time to make a diagnosis was too long. The time to transport the patient to the operating room was too long, but only in 6% of cases was actually notifying the vascular surgeon inappropriately long. So we were not meeting our targets of having 60 minutes to diagnosis, 60 minutes for patient transport. And so we basically fixed this process. We simplified communication, we improved coordination of care, and what we basically did is reduce all these delays that were going on. And so the improvement in process was from about 3 hours to under 2 hours, and theoretically the improvement in mortality is from about 58% to about 35% actual mortality. So had we implemented this in 2015, we could have saved 10 people's lives and reduced mortality by 25%. Now, you can't do live simulation every single permutation out there, and so what we were actually able to do is input many of these clinical variables into a computer model, and this is something that we use a software called Simulate for, and it's a very sophisticated but also very easy to use software that lets you graphically model all the different clinical and human factors that go into all these different processes. So imagine that process map I showed you earlier of the patient going from the scene to the ambulance to the ER to the OR. And if you do this enough times, you start getting averages and standard deviations for all the different variables involved. You can input all that into a computer model and start making changes to your process and see how it affects the output. So I'll show you a much more complex model later on in this talk. So for some of the changes we were able to make, we basically simplified communication. Now the ER attending talks directly to the surgeon, who then activates the operating room, and that eliminated false activations to the OR completely and immediately saved the institution $250,000. It prevented any breakdown in communication and basically made a very efficient critical path. We have a single direct line for OR activation. It's a single point of contact during the day, night, weekdays, or weekends. And now there's no more confusion about who to call or when to call them. The ER immediately prepares the patient for transport. As soon as they have a diagnosis, they know the patient's probably going to go to the operating room. They immediately prepare for transport. There's no more wasted time of an OR nurse waiting for the ER to get ready. And on the other hand, the OR goes to the ER to transport the patient as soon as they are ready. So there's no longer any communication that's necessary. The OR doesn't have to figure out who the ER nurse is or vice versa. Basically, as soon as they're ready, they go downstairs and immediately bring the patient to the operating room. It's a much more efficient process and gives all the stakeholders, which in this case are the nurses, the doctors, the administrators, and most importantly, the patient, a lot more control over the system, a lot more ownership. And when, as we all know, when you start having much more ownership over everything going on, you start working harder, you're more motivated to have a higher level of care, higher quality of care. So the bottom line is that with all of these changes that we proposed, we could save $1.3 million just from one disease at one hospital. And so we're eliminating false operating room activations. We're saving all the costs associated with labor and operating room utilization. And because we're doing it faster, our patients are not bleeding as much, they're not as sick, and so their morbidity goes down. They're not spending as long in the hospital, so we're saving almost $25,000 in care costs per patient, and not to mention a 25% improvement in mortality. So really some truly fantastic results with this. Let me talk to you about live simulation first, because this is kind of one of the cornerstones of a way to do quality improvement prospectively. So, you know, a question I got commonly, we presented some of this information at the international meeting on simulation in healthcare earlier this year, or last year, I think, at a very nice conference, and talked about how we were able to pull off such a large live simulation. And so, you know, this is, the team deserves credit. We had a wonderful team. We had probably a dozen stakeholders, including nursing leaders, quality improvement leaders, and other people that are responsible for coordination of care, administration, and also clinical care as well. We started 5 or 6 months ahead of time. We defined the scenario that we wanted to work on. And so this was a very specific question for us, and you can apply the same thing at your own hospital. If you're trying to improve the time it takes to get a patient who has a heart attack or a myocardial infarction to the cath lab, you can define the scenario and work on that specific group. If you're trying to work on trauma care, you know, you can use live simulation for all these different scenarios. So we defined the scenario. Within a month, we had figured out what all the key metrics were and process mapped the entire thing. And so the easiest way to do this is to pretend that you're a patient, walk into the emergency room with your team, and figure out exactly what happens and how it's done. You're in a live setting, and you know exactly how all the different pieces kind of fit together. And as you're walking through this process, you also get a good idea defects may come from as well. And so that's what we started doing a month after that. So that's T-minus 3 months then in yellow here. And we analyzed the current state of affairs. We figured out what we're doing well, what we're not doing well, and without judgment at this point. You know, we're calculating averages and standard deviations and figuring out what our key metrics really are. A couple months later, we were ready to rehearse this simulation. We did a complete dry run. And while we had a dedicated simulation facility to do this in, you can do this in your hospital, and you can do this in your ER, in your operating room, and you can do it off hours so you're not disrupting clinical processes and other clinical care going on. But rehearse it, and you can use your existing infrastructure to make this happen. And then we did a live simulation. This was actually on TV, in the newspaper. You can find it online. It was really exciting for us, but not just because of the media attention, but because of all the different things we learned from actually having blinded participants go through this entire process. We had a specially trained patient who portrayed all the signs of a ruptured aneurysm. We had actual emergency medical services personnel, an EMS dispatch lady who helped quite a bit. We had actual nurses from the ER and operating room, and an actual vascular surgeon, actual emergency room doctor. And we tested major defects that we had found in the state. So some of the problems we had were delays in getting a CT scan, delays in getting a right diagnosis, communicating with the OR. And so as part of the simulation, we tested those defects. We said, sorry, the CT scanner is not available. What are you going to do? The patient's crashing. What's your response? If you couldn't reach the operating room. At one point, one of my partners actually picked up the phone when the ER was trying to reach the operating room and said, I'm sorry, you got the wrong number. This is Domino's Pizza. And so it's funny in retrospect, but at the time when tensions were running high, we wanted to see how the emergency room doctors would react to that. They can't reach the operating room, and this patient needs emergency surgery. What do we do next? And this was all recorded and was directly observed by quality improvement experts, behavioral experts, education experts. And you have these people at your hospital. You have quality improvement people. You have risk managers. You have nursing educators, and they're all stakeholders when it comes to large projects like this. They're multidisciplinary and interdisciplinary. Now, a month later, we started streamlining these processes. We figured out a new critical path, and we eliminated many possible defects. And using computer simulation, because we had all the pieces in place now, we were able to do a lot of the simulation using a computer model and basically go straight to implementation with a lot more confidence. We didn't have to keep testing this over and over again. So let me show you some pictures from our simulation. So this is our patient, and he's pretending to have a ruptured aneurysm. And there's a video that goes along with this, but I can't show it to you because of streaming limitations. But basically, there's multiple possible defects, multiple possible impacts. So here he faints, he has a lot of pain, he calls 911. We have EMS that comes. These are, like I said, actual paramedics. They come, treat the patient at the scene. They put him in the little gurney and take him to the ambulance. And in the ambulance, they're actually providing care. Now, one of the things we simulated here was his vital signs decreasing. Patient sick, he's hypotensive, tachycardic. How do they respond to a critically ill patient in an ambulance where they have limited ability to take care of a patient? From there, they brought him to the emergency room. This is an emergency room resident that's doing a fast exam or an ultrasound of his abdomen looking for fluid. Again, we've got a vital signs monitor, and there are people in the back through a one-way window that are watching everything going on. They make the diagnosis, and they call in the vascular surgeon, and also an ER attending, and they provide bedside care. They confirm the diagnosis. They review a CT scan that showed a ruptured aneurysm, obviously not in this patient, but in someone else in our hospital system. And if you look at the monitor, you see that he's now tachycardic with a heart rate of 123. He's hypotensive. People are getting concerned. They want to do the right thing for the patient. And so vascular surgeon says, the guy has a ruptured aneurysm, we need to go to the operating room. They mobilize the team. What you're not looking at here is the perspective of all the media that's got their cameras on this and photographing everything going on. So not only do you have the tension of making the right diagnosis for the sick patient, you're on camera. And there are also multiple other people watching the live feed in a completely different room. So even though they knew they were part of the simulation, this was as realistic as we could make it. So they've activated the operating room. Now, obviously, the live patient didn't want to have an actual operation performed. I offered, but he decided not to go through surgery, especially with simulated anesthesia. He thought that would be a bad idea. So at this point, we developed this very nice model of an actual aneurysm, and had a mannequin attached to that model. And here, what's happening is that we have intentionally made it so the vital signs are gone. This patient is crashing. They are coding. This is a code blue. And so the anesthesia team has started CPR on this patient. Vascular surgeons rushing to the room and starting emergency surgery. Now, obviously, this isn't real. But this is how realistic our model actually is. We had like this fake blood substitute. We had like this aneurysm that looked very realistic. We had fake intestines and fake fat and skin and everything. And so the surgeon and his team actually did the operation on this patient, more or less like how they would do in a real patient. So this is as realistic as you can make it. Very exciting, but also, like I said, very, very informative. Now, for this particular simulation, the patient survived the operation, and he's brought back here to the intensive care unit. Now, we're monitoring things like handoffs, communication between nursing, interactions and coordination of care. We're looking at the processes involved. How does the ER react when the CT scanner is not available? How do they react when the OR is not answering their phone? How does the OR react when they can't reach anyone in the emergency room? And so we're watching all the ways that people work through these complex situations that they actually see in real life, but we never really have a chance to monitor. So live simulation gave us a huge, huge benefit and a major advantage. And what we were able to do is really meet the 6 aims of the Institute of Medicine, and that's to provide safe, effective, patient-centered, timely, efficient, and equitable care. And I'm going to go through these one by one. So we did this simulation in a clean environment, and we were able to test clinical strategies without any risk to a patient. So say at your institution you're trying to remodel a pathway. Say that there are issues with coordination of care between the operating room and the ICU. There's a delay. You can't quite get the right drug started in a prompt enough manner. Simulate it, and you can use your existing infrastructure to make it happen without any risk to patients. It's all in a clean, safe environment. Effective. It allows team building and cross-training of different disciplines because there's a debrief session that's involved for education as well. And one of the big benefits of cross-training in this type of environment is that because you're in a place where people can drop out of the simulation and watch what other people are doing, all of a sudden you start getting very special insight into all these different processes. And so when next time your ER nurse calls your OR nurse with a ruptured aneurysm, they understand it better. They know how urgent this is, all the things involved, and they can communicate and coordinate care significantly better. It's patient-centered. The goal is to improve patient care. And so time is set aside for mission-critical clinical pathway development. And I'll define what I mean by that in just a few minutes. But basically, you're all working towards a common goal. The patient's at the center of this operation, and that is your focus. It's timely. You have real-time feedback that's possible, and you have direct observation of the different defects that go on. Not just the ones you created in the system, but new ones that crop up out of this. It's also efficient. If there's collaboration between quality improvement and clinicians, you don't always get that. You know, your Lean Six Sigma team and nursing educators and quality improvement team are often divorced from the actual clinicians, the surgeons and the primary care providers, and because of that gap, that's a major hurdle in terms of being able to communicate with each other. This puts them all in one room and allows testing of multiple defects as well. So another major benefit of live simulation. It's also equitable. You get objective assessment of strengths and weaknesses, and it's focused on systems-based issues. It's not punitive. You're not trying to blame a particular department. The goal here is to make care better for everyone. So we had a variety of different goals and objectives. We had half a dozen things that we were actually going to test as part of the simulation based off our observation of other processes and things that have been brought to us from risk management and others in terms of various defects that have been observed in the system. And what we were able to do is simulate almost every single one of those defects as part of this 4 or 5 hour long simulation that we did. And in the process, we changed the clinical processes in the hospital to mitigate that risk to the patient. Now, this is a fantastic achievement by itself, but this is what I'm most proud of. Without harming a single patient, there's no near miss, no actual incident of patient harm, no root cause analysis. We found 3 completely new defects, and every single one of these could significantly adversely impact patient care, whether it's a wrong diagnosis or premature activation of an operating room or just improperly stocked emergency department supplies. Things that you wouldn't necessarily find unless there was a near miss or patient harm event, we were able to uncover just because we were doing a live simulation with a critically ill patient. And so we improved those clinical operations as well, and we did it prospectively. So that's the live simulation component of all of this. Now I want to talk to you briefly about computer modeling. And you know, when you start thinking about computer modeling, you start thinking about all these statisticians and math and these complicated programs, and you just don't want to play with it because you don't have the expertise or the time to sit down and learn it. But let me tell you that that's not the case with a program called Simulate. Now, this is a readily available, easy-to-use program that has a very nice graphic user interface, a very low, easy learning curve that gives you this flexible, scalable test environment and allows approximation of these real-world scenarios. Now, you're able to adjust key variables to determine potential clinical impact. You know, if you're simulating a clinic situation, which I'll demonstrate to you shortly, you can actually determine how many patients are walking in the clinic, how many nurses that you need in the clinic to make your throughput efficient, how many medical assistants, how many doctors need to be there, even how many patient rooms you actually need to have an efficient operation. Now, because of this flexibility, you also have the ability to do rapid prototyping of many different pathways to figure out what the optimal solution is, what we call the critical path in quality improvement. And so what we used to do was have these Gantt charts and all these performance measures and timelines, and you're dealing with a dashboard like this where you can't even read some of the small font for the project plan. And it starts getting to be a little bit ridiculous and hard to work with. So what Simulate does is that it takes all this complex charting and database work and everything else and puts it directly into a graphic user interface and into the simulated model. So I'm not sure how well this will transmit through the webinar, but what you're basically looking at is a simulation I created of our clinic processes. And this is basically people coming into the clinic. We have two people that checks them in, a medical assistant that helps enter vital signs and data entry, a doctor, in this case it was me who was actually seeing these patients, and a nurse that helps with the checkout process and everything else. Now what you're looking at here is actually the 6th iteration of this process. And what we were able to do is see as many as 20 or 30 people in our clinic and also do a dozen different procedures related to various types of vascular diseases in our clinic. The annual impact of this project was $1.2 million. And we modeled the whole thing using this computer modeling program and then implemented it. In this case, there was actually no simulation. We just went from figuring out what all the defects were, fixing them using computer modeling, and going straight to a live scenario. And it worked well because of all the work and preparation that we did putting into this project. So as you can see, if you're looking at all the pie charts at the bottom of the screen, it also gives you lots of different metrics in terms of how efficient your employees are, how long they're spending doing various objectives. And if you're looking at the block in the red on the pie chart, how often other things are preventing them from doing their job. So if you're looking to add personnel, decrease personnel, or make your operations more efficient, this is a great program to make that happen. And it's prospective, no patient harm has to happen. All you need is quality data, which many of us are good at getting from our hospital system. So let me put all this together, the live simulation piece and the quality improvement piece. Basically, what we did, we followed the DMAIC model. So D for define, we define the problem. And so whether it's poor communication between hospital units or a complex clinical environment or just a siloed model of healthcare, you know, your ER doesn't talk to your OR, doesn't talk to radiology, doesn't talk to pathology. They're all different practice groups or they're not friends with each other, or whatever it is. Healthcare continues to be very much siloed and independent. And so you start getting problems like not being able to provide timely or safe care. The complexity, the unnecessary complexity starts making things inefficient. And because everything's siloed and duplicated, things are not effective and it's not patient-centered. So you can use this approach to defining any problem you want to deal with in your healthcare system, whether it's something that another doctor brings to you or a nurse brings to you or risk management or part of a peer review process. You can use this model to kind of define everything going on. And then measure the performance. Now, in this case, we use live simulation, but you can just as easily measure these defects by looking at prior instances, calculating averages and standard deviations, or even computer-based modeling. Figure out what people do, how they do it, map it all. And so the mapping is part of measure, it's also part of analyze. And so analyze the findings using Lean Six Sigma. Basically what this is that it gives you a data-driven method for having quality improvement. What you're looking at here is a control chart, and it tells you what your specification limits are, your upper and lower control limits, your average performance, and where you actually stand on that chart. And so when you start going above your upper control limit or have other defects, then all of a sudden you can kind of pause and say, wait a minute, why would we offer baseline that particular month? If UTIs were particularly high in the month of February and you want to figure out why so many patients had a urinary tract infection, get a control chart, analyze those findings using Lean Six Sigma principles, and figure out whether or not that really was something that was sticking out of your normal limits. And if it was, you now have a quick and easy way to figure out when you're doing well and when you're not. And that you can go back retrospectively, figure out what this situation was at that point, and you may have a quality improvement project and completely eliminate UTIs, or in our case at a hospital I used to work at, eliminate surgical site infections, which is fantastic. And it's evidence-based, it's math-driven, it's easy for people to understand, And it's a common language that doctors, nurses, and quality improvement experts can all speak. So you put that together using Analyze. I is for improve. You can improve performance using team training and clinical process design. Team steps, I'm a master team steps certified trainer, and basically my feeling on team steps is that I think it's a valuable way of providing a structured environment and structured protocol for people to communicate with. But if you're going to be successful applying team steps, you have to customize it for your institution. It is not a one-stop shop. You can't just say, oh, I'm going to start doing SBAR at my hospital. It doesn't work that way. And so what you see here is that at my previous institution, we actually implemented SBAR, and it's a way of it's a universal team steps handoff method that any provider can use when communicating, and it actually works pretty well. And so team training is one way of improving performance. Now, this clinical process design is when you sit back, you map out your existing processes, you figure out all the things that you currently do, and then you do a simulation or computer modeling and figure out where all the different defects are, and you basically figure out a way to streamline that process. You simplify communication, you simplify the handoffs, you make it easier to get to a CT scanner, you define a protocol for use for some of these things, and all of a sudden you now have intentional clinical process design. The last part of this is to control the findings through policy changes. And I can't tell you how important it is when you're dealing with all this in a prospective manner. And the reason why it's so key is because when you're doing quality improvement and error correction from a prospective way, you're making lots of changes to the system. You're modeling it, but at the end of the day, you've changed the way your stakeholders provide care to patients. You change the way that nurses communicate, that doctors work with each other. And so you have to control those findings. And so that involves policy changes, a clear protocol, having both a beneficial and even a punitive way of reimbursing and potentially punishing doctors that are not following a better way of doing healthcare. Now, in my experience, the punitive aspect is actually not that major, because what you do is you include anyone who's going to raise an objection to be part of your change team. You make them stakeholders. When they have their skin in the game, all of a sudden people are cooperative. They want to make things better. There's a team-based ways that you can apply many of these ways and changes to the system. And all of a sudden everyone has a piece of this, and they want to see it succeed. So the resistance to many of these things is pretty minimal. Now, that's at the clinical level. At the financial level, very important to have your financial numbers straight. You want to have a business that's necessary if it's a major capital expense or major expenses to the system. And you also want to be able to go through your profit loss statements and things like that, just to be able to understand what all the different financial factors are. And that's how you sell it to the C-suite. You know, if your CEO or CFO comes to you and says, Dr. Desai, why am I buying a $1 million CT scanner exactly? And if you can pull out the paper where you show the beneficial impact on patient care, how you're saving that hospital $1.3 million a year, all of a sudden it's like, well, maybe we should have 2 CT scanners. And so really what this is an evidence-based prospective clinical pathway design. And so the benefits of this are that it anticipates clinical needs, it's intentional and efficient critical path development, it allows mitigation of multiple failure modes, and you can use systems-based tools to avoid defects. Now you're looking at the entire spectrum of care from start to finish. You've eliminated silos. You're not just looking at the ER or OR radiology. You're looking at everything, the flow of a patient through the system. And most importantly, no patient harm event is necessary. There's no near miss. Your risk management team and corporate lawyers are very happy. Your traditional retrospective root cause analysis pathway, it certainly has its place in medicine, but unfortunately it develops solutions to specific patient harm events or near misses, and because of that has a very narrow focus that doesn't really prevent other causes from leading to the exact same defect. And it's a reactive strategy that truly increases liability, because imagine, you know, if anesthesiologist gave the wrong drug one day and you think you fixed the problem, you go back to the family and say, yeah, we figured out what the problem was, we fixed it, it'll never happen again, and 1 week later it happens to their friends. Guess who doesn't have faith in the hospital system anymore? This is something we see over and over and over again. And this is where a prospective clinical pathway design can completely mitigate that risk. And finally, with the traditional retrospective root cause analysis pathway, we can't really implement that without a near miss or actual patient harm event from occurring. And so what's the point of all of this? The final result is that, right now we have a very regimented, silo-based model of healthcare. The ambulance, the paramedics in the ambulance just want to get the patient to the emergency room and hand them off. In the ER, they just want to get a rapid diagnosis and hand them off to the operating room, and from there they just want to go quickly to the ICU. When you start having this intentional pathway design, coordination of care among different disciplines, interdisciplinary training, cross-training, what you get is this. You get a very streamlined model of healthcare. There's handoffs in both directions. There's cross-training that goes on. Administration, senior administration kind of flow with all of this as well, because now they truly understand all the different processes going on, their role in making all the stakeholders happy, and you start getting quality improvement that happens throughout this process. It's a spectrum of care. So I certainly hope all this has been informative and helpful. I know that this is kind of the 10,000-foot view to making this happen, and there's a lot that kind of goes into this. A lot of specialized skill sets like understanding the language of quality improvement and education, statistical analysis, being able to collect data reliably, being able to coordinate care, even team steps type training. But if you look closely enough at your institution, you'll find many people who have one or more of these skill sets, and it's easy to go and get some of the specialized training. It doesn't take very long, and the ROI, the return on your investment, is huge. So thank you again for the opportunity. It's been my pleasure to present today. And feel free to reach out to me by email or otherwise with any questions, and if you want to copy the slides. And once again, thank you to Mary Ann and the IHF for this wonderful opportunity.
Thank you, Dr. Desai. We will now go ahead and take some time for questions. Just a reminder, please type your questions into the questions pane and click send. So the first question is, what sort of team would you recommend putting together to use your innovative approach to quality?
That's an interesting question. Thanks, Marianne. So the team that you need really depends on who's involved and what the project is that you're working on. Say that you were working on blood utilization of the OR, and your concern is that you're using too much blood. There's a kind of a reactive ordering system where if the hematocrit drops below 30, you automatically order 2 units of blood. And you want to fix that system. That's not evidence-based anymore and actually takes away from patient care. So, the key is to identify who the different stakeholders are. Who are your biggest users of that blood product? That's a key stakeholder. Who you want to get the blood bank involved. You want to get the operating room team or the leaders in the OR involved in this as well. If there's major financial issues that are also happening here, then you want to get someone involved from a Lean Six Sigma standpoint as well, because they can help you with the financial analysis. If you're dealing with a situation where communication breakdowns are very common, you want to get both sides in the room together. So if it's an ER to OR transition issue or handoff issue, get the ER nurses and OR nurses involved. You don't need every single one, but at least a leader that represents many of them is a good way to do it. And finally, you're going to need some sort of a quality champion that understands all these different realms and who can coordinate the entire team. In my opinion, what's worked well is some sort of a clinician that also understands quality improvement, Lean Six Sigma, and can kind of coordinate all these different things at a high level. That's a good way to start with a team.
Okay, thank you for your answer. And then, can this live simulation be done in actual clinical setting, or does one need dedicated facilities to do so?
Yeah, we at Memorial Medical Center in Springfield, we were lucky enough to have a beautiful 4-story building that had simulation, a very nice simulation setting, and an ER, OR, ambulance, and things like that. But it's very nice to have that, but you don't need to have a dedicated facility to be able to do live simulation. In fact, in some ways, it may actually be better to use your actual clinical environment, because now you don't have the capital investment. You're not busy trying to set everything up in a completely different building to make it match a real-life setting. You can actually do this where patients are taken care of and watch the entire process in a very realistic, actual clinical setting. So anyone can do this anywhere in the world using the facilities they have at hand.
Okay. Can this clinical process design pathway be used in non-surgical settings?
Oh, for sure. Surgery is an easy way to figure this out because, I'm a surgeon. If I see an aneurysm, I want to fix it. It's a kind of a knee-jerk response for me. But it doesn't. You don't need to have a situation that's as clearly cut. You can do this in a medical setting or really any type of setting to make this happen. And so an example of this would be, say that you have this gap in care from when a patient's admitted from the emergency room and they go to the floor. And so if you're admitting someone who has who's an alcoholic, and you need to put them in a van and get them off, and basically prevent delirium tremens from happening, then if you've got like a 6-hour delay in care where you've got this vacuum and no drugs are being given, that's an ideal situation to do a live simulation and then do some computer modeling. Pretend to be a patient, go to your ER, see how they diagnose you, see how long it takes to get from the ER to the floor, whether it's a transport issue, a coordination of care issue, or communication issue. Are the orders not being activated? Is this a clinical pathway where a doctor is responsible, a nurse, or operations or utilization management? Who's involved? You'll find that it's multispectral. There's many different parties involved, multiple different stakeholders, and the tangential benefit you'll get from a project like that is that you'll streamline transition of care for not just an alcoholic patient, but really anyone that enters your system. And so we did a similar project like that with patient placement and had a huge improvement in throughput. So it doesn't have to be surgical. It can be any clinical pathway.
Thank you. We still have time for 2 more questions. We invite everyone to type them into the questions box and click send. Another question, do you foresee this replacing the traditional root cause analysis method for correcting defects?
Yeah, I think that it's not going to replace the traditional way we do root cause analyses. When you're dealing with peer review and sentinel events and things like that happen in a hospital setting, I think doing a properly structured RCA certainly has its place. But imagine the power of being able to do a root cause analysis, but then go back and figure out the entire pathway that's responsible for this and correct a variety of other defects. What you're actually doing is fixing a variety of other causes that can lead to the same problem, the same defect. So it's a way of augmenting and empowering the traditional root cause analysis pathway.
Okay, and how do you see this fitting in with peer review?
I'm sorry, how do I see this feeding into what?
Peer review.
Oh, so in terms of like implementation and what's next, I think we're going to present a version of this talk at IHF later this year in South Africa. But basically, I think that as more and more people get involved with team steps and they learn the proper way to do quality improvement using Lean Six Sigma and other tools, we're going to start seeing a much closer marriage between many of the QI experts and the clinicians. One of the great things you can do is actually start teaching your clinicians the language of quality improvement and empower them to be physician leaders. This is a great way to bring people together in a room and get everyone kind of excited about improving the quality of care we provide to our patients, but also empowering them to make changes. So if someone sees a better way to take care of a patient, all of a sudden they've got the tools to be able to start working with others in a collaborative environment to implement change. As long as it's done keeping the entire system in mind, all it's going to do is improve the care for everyone. So I think this is a great way to start. It builds collaboration, it builds coordination of care, and it builds cross-training and makes us all better physicians and healthcare providers. So to me, I think this is what the future of quality improvement and better healthcare is going to look like.
Thank you. It looks like we've covered all of our questions. Dr. Desai, is there anything else you wanted to cover before I wrap up?
No, I think that was it. Once again, thank you for everyone who's still here and for the opportunity to present tonight.
Okay, thank you everyone. Thank you, Dr. Desai. It was a pleasure being with you today, and thank you for sharing your valuable knowledge to everyone. And we appreciate you being here. Today's webinar will be available on demand at the IHF website. You will also receive an email with the link to view the recording of this session. Thanks again for joining us today, and we'll see you next time.